Okay, my name is Julian Gore-Booth. I'm the CEO of the World Federation of Societies of Anaesthesiologists. And thank you to our friends at Lifebox. I've been invited to give a masterclass here at Anaesthesiology 2019. And I'm going to talk about global anaesthesia and the question, global anaesthesia, something to shout about. Now, I think global anaesthesia is something to shout about, and part of this talk is going to be why, and also trying to explain a little bit about what you can do to shout about global anaesthesia. So whenever I talk about the globe, I think it's important to recognize that people's view of the globe is very different. My view of the globe as a child looked a bit like this slide. That was my vision of the world. That was the map that I used. Other people's view of the world, depending on where they're from, might look something a bit more like that. But don't forget that if you're a Pacific Islander, your view of the world will look like that. Now imagine trying to provide safe anesthesia and surgery in that environment. There are people there, but it looks like sea. So we have a lot of different challenges facing the provision of global anesthesia. For those of us that get excited about global anesthesia, and I suggest that should be all of us, we had a seminal year in 2015 when we were given really a platform to be able to move forward with this agenda. And that's split between three things: the Lancet Commission on Global Surgery, the World Bank's Disease Control Priorities Report, and subsequently the World Health Assembly's Resolution 68.15 on strengthening essential surgery and anesthesia. What that did was it enabled us to bring some really, really hard-hitting messages across to the global decision-making influencing community. The fact that 5 billion people are without access to safe and affordable surgery and anesthesia is, I think, a human rights travesty. It should be an issue that concerns us all, and yet not many people knew that by far the majority of the population of the world couldn't access what most of us would consider to be a basic human right. The other messages show you the scale of the problem. You know, we're about 140, 150 million surgeries short every year of where we should be in terms of the volume that should be being provided. The DCP3 World Bank publication was also extremely important. It showed us some of the economics around surgery and anesthesia, that this shouldn't be considered to be such an expensive luxury, and that actually some of the returns on investment are really hugely important. Both Lancet Commission and DCP3 estimate a return of $10 for every dollar invested in surgery and anesthesia, based on the economic productivity that you will not then lose because people are able to return to the workplace, able to look after their families, get on with normal life, contributing to their economies. The estimate of $3 billion a year to be able to provide essential surgery and anesthesia at the district level hospital, that is a global number. It is a tiny figure. It sounds huge, but it is a tiny number in terms of global health financing. And yet we could do this. We believe we could achieve this for that amount of money. So this is a very investable proposition, and it's what we need to be doing today. But we have to persuade ministers of finance as well as ministers of health of the importance of this. The World Health Assembly resolution, which I like to think of as our resolution, so anybody who's involved with safe anesthesia and safe surgery, we think of this as our resolution. This was unanimously supported by all ministers of health at the World Health Assembly in 2015. And that's a phenomenal support for the resolution. But 80% of World Health Assembly resolutions achieve nothing. We want to make sure that we're in the 20% that does achieve something, and this doesn't remain a piece of paper, but it actually goes on to become something which you can implement. And it is interesting today actually that I'm standing here with people from some of the countries who are implementing national surgical obstetric and anesthesia plans, and these are one of the ways in which we can start to move the agenda forward to make sure that resolutions actually start to make change on the ground in people's lives. The global goals for sustainable development, or the SDGs, of course include the SDG number 3, which is our goal. It's the goal for good health and well-being for all. The problem with that goal, and the problem that we face as advocates for global anesthesia and surgery, is that it didn't include mention of surgery and anesthesia in the description of the goal or in the indicators which are used to measure it. However, we have gone on to have some success after that. So the WHO produces a list of 100 core indicators. You won't be able to see that, but on the next slide you can see that we're beginning to have some influence, because perioperative mortality rate has now been included as one of the key core 100 indicators, and also health worker density and distribution, which would include a breakdown to ensure that you had numbers of surgeons, numbers of anaesthetists and numbers of obstetricians, so that you could start to see if you're getting closer to the target of 20 specialist surgeons, anaesthetists and obstetricians per 100,000 population. So we're starting to see an influence also on data, and you cannot make change unless you have data. So this and good data and comparable data. So this is a move towards helping us to influence the agenda. I'm particularly interested in anesthesia. We are short of 2.2 million specialist anesthesiologists, surgeons and obstetricians worldwide, but a huge number of that is related to anesthesia specialists, trained anesthesia providers. And you can see here some of the key numbers. 90% of anesthesia departments in a lot of the poorer countries of the world wouldn't be able to provide a safe anesthetic for a child because they haven't got the equipment to do so. And there's still a huge lack of pulse oximeters and pulse oximetry around the world. Lifebox is doing an enormous piece of work around making sure that pulse oximetry is more available, but the gap remains huge. Despite those efforts, more needs to be done. This shows you how you can affect maternal mortality by having the right trained people in place. If you look at the slide, you can see that if you manage to reach a workforce density of surgeons, anesthesiologists and obstetricians of 20 per 100,000, you can really bring down maternal mortality rates. And you can stretch that across all mortality rates. It's all about having the right workforce. I call this workforce optimization. It gets called a lot of different things, but I prefer the phrase workforce optimization. Who are the people you've got? How many do you need? And do you have the right people in the right place at the right time with the right skills and competencies to be able to deliver safe surgery and anesthesia? The numbers of anesthesiologists in different countries varies enormously, and this slide shows that. So we have huge challenge between some of the richest countries in the world and some of the world's poorer countries, like Tanzania, where you can see that they've been making huge efforts to increase the numbers of anesthesiologists. But as they reach numbers around 50 or 60 anesthesiologists in the whole country, that's a tiny figure compared to the number of anesthesiologists that they actually need. So that's a huge challenge. It's got to involve the Minister of Finance as well as the Minister of Health. This map shows you where the biggest workforce challenges in the world are, and you can see that it is as you would expect. It's across the world's least resourced countries, but it makes it even more important that investment happens in those areas, because those are the populations that are amongst the 5 billion that are not receiving safe surgery and anesthesia today. That's a comparison between Belgium and Tanzania, just to bring it into perspective, to show you the kinds of differences that we face. Here in the United States, we have around about these numbers of anesthesiologists as well, but they also have almost a doubling if they include nurse anesthesia providers. So they actually reach a number of around between 35 and 40 trained anesthesia providers per 100,000 population, compared to 0.1 in Tanzania. That's a massive, massive difference. So it shows you some of the challenges. The challenges are not only about people, of course. Safe anesthesia is about people, it's about equipment and infrastructure, and it's about medicines, and getting those things together in the right way. This is a look at distance to hospitals. You can see that low and middle income countries, people have to cover huge distances sometimes to get to hospital. High income countries, we take it for granted that we'll have a pretty well equipped hospital not that far away. In a study of 22 low income countries, they looked at the type of anesthesia offered, and you can see reliance on ketamine not always having available regional or general anesthesia, which you would expect to always have available in the world's richer countries. So again, you've got different types of anesthesia provision. You can't expect to have running water, electricity and oxygen, which you would take for granted in many countries of the world, available in all hospitals around the world. It just isn't. So the things that we assume, we should not be assuming. We make assumptions all the time. We would assume that a surgery would have water, would have running water. It is not always the case. We would assume an anesthesia machine, again, not always the case, and we would assume a pulse oximeter, again, not always the case. So this data helps us to advocate and to make the argument for why these things need to change. The other piece of data that I really like is that anesthesia safety has been improving over the years. This is a really good story, and it's a story that is like a huge kudos to anesthesia educators, particularly educators, to say, you know, how have you managed to actually make anesthesia safer? And this applies around the world, wherever anesthesiologists and anesthesia leaders are present. The mortality has been going down over time. But if you include some of the studies from low-income countries, you can see that actually in some places it hasn't been going down, and that's wrong, because all anesthesiologists, trained providers, they know what makes anesthesia safe. They know how to provide safe anesthesia. So this shouldn't be happening. And if you look at some of the smaller studies from other countries, you actually get disparities of 1,000 times. In other words, mortality 1,000 times higher in some countries than you would find in the richest countries of the world. That's a human rights disgrace, and it's something that we should all be involved in addressing. I'm not going to spend too long talking about the work of the WFSA, but we are involved in training. We're involved in obstetric anesthesia training, pediatric anesthesia training. We're involved in simulation training, which is a really good way to get learning across. We're involved in training around pain. Pain is frequently ignored in low and middle income countries, and yet is a huge issue. I was just reading an article about pain after C-section. Quite often not much is done about that. It's not even recognised, let alone assessed or treated. And this course helps us to look at those kinds of issues. Publications and online publications are also very important, and I would encourage people to go to the WFSA website and also to the eSafe website, which you can access through us, and access the virtual library, access some of the WFSA's publications, and see if there's something there that will work for you. The latest one is on obstetric anesthesia. This is going to be a hugely popular edition, because the most common type of anesthesia being provided by specialists in low and middle income countries is obstetric anesthesia. This is going to be the most common. The one that's the most scary is probably pediatric anesthesia. The one that's the most common is definitely obstetric anesthesia. So do access that edition through the WFSA site. There is progress being made. Another area where we are particularly active is in providing international guidelines around a safe practice of anesthesia. Countries can use this if they don't have a set of guidelines already themselves. They could use it to establish their own set of guidelines, and they can also use it to lobby with their governments and decision makers to make sure that anesthesia is taken seriously by those people with influence. We mentioned national surgical and anesthesia plans earlier on. There's a number of countries now across sub-Saharan Africa, Southeast Asia that are involved. I think there's 16 plans currently either completed or ongoing. This is a huge advance. You can use the anesthesia facility assessment tool to do a bit of gap analysis in your hospital, and then you can take that to national level, and you can use the results of that freely available tool to also then start bringing data which you can use to lobby your decision makers in your country. There is some success with this. We need lobbying at national level, and so if I come back to the theme of the talk, something to shout about. There is something to shout about, and we do now begin to have the tools to be able to shout and make a bigger noise. The African Surgical Outcome Study was picked up by mainstream media. We don't get picked up by mainstream media that often, but when we do, it's quite often going to be stories like this, which showed some astonishing figures. In this one, they showed, and they're going to do a second study that I think might produce even more difficult numbers. You are 50 times more likely to die from C-section or complications in Africa or in sub-Saharan Africa than you would be in high-income countries. Again, I would say that's a human rights issue because it just simply shouldn't be happening. I would also say that in Africa, the current C-section rate is around about 5%. In some countries, it's about 2%. It should be around 10%. WHO says up to 15%. So if we were to take C-section to that volume in Africa and yet maintain this mortality rate, that would be another disaster. And that leads me on to the next thing, which is that when we get this kind of coverage, I think we as the anesthesia and surgery community need to make sure that we're talking about quality as well as about access. You have to talk about both of them at the same time. We can see that post-operative or perioperative deaths are the third leading cause of death worldwide. Now, most people know that heart disease is the leading cause of death. That's quite well known, but not very many people know that post-operative mortality, perioperative mortality, is the third leading cause of death around the world. And if we look at the next slide, you can see that actually more deaths, this was in the Lancet, there's more deaths due to poor quality care than lack of care. And this is where anesthesiologists and trained providers in surgery and anesthesia are so important, because you've got to look at access and quality at the same time in order for us to be doing this right. To finish, two more slides. There's progress being made even at the highest levels. So at the World Health Assembly this year, the editor of The Lancet, Richard Horton, he consulted his social media, and he has a lot of followers, and he said, right, I'm going to be standing in front of 194 ministers of health. What would you want me to say to them? And what they came back with, he then turned into 5 demands. And the 5 demands included climate change, women's rights, and also invest in safe surgery and anesthesia. And Richard Horton talked about those 5 billion. Now that puts safe surgery and anesthesia up there with climate change and women's rights on the agenda. And I think that is exactly where it should be. Subsequent to that, at the UN General Assembly, just a couple of months ago in New York, for the first time, we got some attention to surgery and anesthesia at the highest level of decision making, which is the UNGA. And this is that example. So finally, when they were discussing universal health coverage, they finally made mention in point 35 of their political declaration of surgery. The WFSA's tweet in response was, what happened to the and anesthesia? Or what happened actually to anesthesia and surgery? Because that's the way it should be expressed. Nevertheless, that is progress. It's a huge calling card for the anesthesia and surgery community to be able to use. So between those two, the World Health Assembly and now the UN General Assembly, surgery and anesthesia is getting onto the agenda. I hope that we'll see everybody at the World Congress. If you're interested in these themes, do come to Prague in September 2020. And all it remains for me to say is thank you very much to Lifebox for asking me to come and speak at the masterclass. It's a subject that means a lot to me, and I hope that you'll get out there and shout about global anesthesia.